Hello viewers, welcome to the another episode of Beat Diabetes. Today we are going to discuss on a very important issue, diabetes in women. It is noted that women with diabetes have double the risk of developing cardiovascular complication as compared to the man, and they are also prone to develop other diabetes related complications like diabetes involving the kidney and diabetes involving the other organs of the body. Diabetes in women is also important because women has to pass to the different stages in her life, be when she enters into the reproductive age group, she becomes pregnant, becomes a mother, and when she enters the menopause. All these phases of in the women's life poses a great challenge to the healthcare provider for the treatment of diabetes in the women. To discuss all these important issues, we have an expert panels who are going to discuss the various issues related to diabetes in women. To my extreme left is Dr. Prasun Dev, who is a consultant endocrinologist from KIMS Hospital, Hyderabad. Welcome, Dr. Prasun.
Thank you.
To his next is Dr. Sailesh Loda, who is head of the department and senior consultant, diabetes and endocrinology, Eternal Hospital, Jaipur. Welcome, Dr. Loda.
Thank you, sir.
To his next is Dr. S. Sridhar, who is a consultant endocrinologist and head of the department, MIOT, International Hospital, Chennai. And to the extreme is Dr. Pradeep Dalwadi, consultant endocrinologist and diabetes, Pratham Endocrine Clinic, Surat. We start with the Dr. Prasun Dev. Dr. Prasun, what is diabetes in the women? Is it different compared to the diabetes in the men? And the different phases I told you in my initial inaugural talk, during reproductive age, during menopause, does it pose challenges for the treatment to the doctor? What is your opinion?
Now you will have to understand that in terms of the diagnostic criteria of the disease, that is, when does your doctor call you a diabetic, is not different between men and women. The same numbers, the same high levels of sugar which diagnoses a man as having diabetes is the same numbers as the woman would have when she has been diagnosed to be diabetic. So is it a different disease? No, it is the same kind of disease. But are the complications different? And that they are. And we know that there are certain things, specifically for example heart diseases, which women are far more susceptible if they are diabetic. You know that the estrogen hormone actually ends up protecting the women from having heart disease, and that is why young women are less likely to have heart diseases. This estrogen protection is taken away by diabetes. And so in a younger person, if a woman develops diabetes, the chances of her having a higher chance of having heart diseases is far higher. And as you point out, the various stages of the women's life cycle, there are some unique challenges if the patient is also a diabetic. When she starts having her periods, that is when she enters menarche, polycystic ovarian disease, as you all know, is a very common problem in India, and that has it as its root insulin resistance, which is also a feature of type 2 diabetes. Childbirth, of course, we are going to discuss subsequently. And lastly, menopause has its own unique challenges in terms of diabetes. If a menopausal woman also is a diabetic, the chances of complications are far higher.
Dr. Sailesh, do you think that diabetes in the women have more chances of developing diabetes as compared to the men? And what are the risk factors, what are the common issues with the women which makes them more prone?
Actually, the incidence of diabetes is similar in both the sexes in general, but women are more prone to develop diabetes because of several reasons. Like they are more prone to depression, and as Dr. Prasun alluded to, they have PCO which is another common ailment of young women. This PCO, depression, and the drugs used for depression, they all make the women more prone to develop diabetes. And another social reason in our society, particularly where gender bias still exists, women are not treated equally in certain societies. They are sometimes forced to eat unhealthy diets, and obesity as such is increasing over the recent years markedly in women.
That way women had enough time to take care of themselves, rather she takes care of the whole family. Dr. Sridhar, now it comes to a very important point. Now the question that how you are going to diagnose diabetes, what symptoms will bring to you, and what tests you are going to advise to the patient when the patient is not pregnant, when the patient becomes pregnant. Are there any different criteria for making the diagnosis?
In non-pregnant ladies, the diagnosis is not different from men. Any random blood sugar more than 200 milligrams is indicative of diabetes, but the gold standard will be a glucose tolerance test.
Good.
Where the patient is given 75 grams of glucose. If the fasting value is more than 126 and 2-hour value is more than 200 milligrams, then it is indicative of diabetes. The same GTT or glucose tolerance tests can be done in pregnancy around the 24th to 26th week, and the criteria is lower, the sugar values are lower, and if the fasting is greater than 92 milligrams and the 2-hour value is greater than 153 milligrams, then it is indicative of diabetes.
I think it is also mandatory to screen the patient at the first antenatal visit, because patient might be having diabetes before she becomes pregnant.
Absolutely.
And she might not be knowing. Pradeep, a very important question to you. What are the common problems faced if a female is a diabetic or the female develop diabetes during pregnancy?
Gestational diabetes, that means diabetes that occurs during pregnancy. It has lot of adverse maternal and fetal health consequences. If you talk about fetal adverse health consequences, the commonest one is macrosomia. Macrosomia means large size baby, a baby weighing more than 4 or 4.5 kg. This is because of passage of extra sugar from the maternal to the fetal circulation, which stimulate insulin secretion and subsequently lead to macrosomia. Second important complications, if the blood sugar is haywire, particularly during the last trimester of pregnancy, it can lead to intrauterine fetal death. Let me tell you, during the time of the delivery, if the child is large, it can lead to adverse maternal and the fetal injury as well. And immediately after the birth, child may have recurrent hypoglycemia, that means low blood sugar level, and may have respiratory distress. Again, later on in the life, child are at increased risk of development of diabetes mellitus. Now, if you talk about maternal health consequences, gestational diabetes mellitus can lead to increased risk of hypertension and preeclampsia. Preeclampsia is a condition where mother is having extremely high blood pressure, along with that she is passing protein in the urine, which lead to adverse fetal health consequences and sometimes can lead to premature delivery. And second, if the woman is having history of gestational diabetes mellitus, later in the life she is at very high risk of developing type 2 diabetes mellitus. If the mother is diabetic and is not having good glycemic control during the first half of the pregnancy, during organogenesis, at that point of time, if the high blood sugar level can lead to some teratogenic effect, that means a structural abnormality in the fetus, maybe in a form of neural tube defect or in a form of some structural heart defect.
On that note, we will take a short break. We'll be right back.
The hopes that you bring, the dreams that you share, the pleasure you get when you know that we care, the faith that you place, the trust that we share, the joy in your heart when you know that we care. You before we at USP, you before we at USP.
USV, your reliable healthcare partner.
Now, this is very common social custom in our practice that female who deliver the child are being fed with very high caloric dense foods. Wrong or indirect consequences of taking high caloric dense food immediately after delivery, even either she has developed diabetes during pregnancy or either she is a diabetic.
Right.
So your opinion?
Yeah. If the patient, if the mother has had any kind of diabetes during the course of pregnancy, even if the mother has become normoglycemic, even if the blood sugar has normalized after delivery, she still needs to be careful. So high calorie food is not indicated in these patients.
That is a very important message for
The simple reason
audience.
that it has been shown that people who, or ladies who are diabetic during pregnancy and then they become normoglycemic, their sugars become normal, over the next 10 years, they are more likely to become diabetic in the long run. The restrictions that you had during pregnancy still needs to continue, and whether you need medicines or not, that your doctor will decide. The other point is, it is important that 6 months after the delivery, they should actually get a blood sugar tested, and they should keep testing it at least once a year.
So same with the continuation, Salish, very common question that when a lady comes to a doc, what are the chances of developing diabetes in my baby because I am a diabetic, and what can I do so that my child doesn't become diabetic? What is your opinion?
The first thing which is reassuring is that soon after the birth, the child is not going to develop diabetes. The diabetes would develop several decades later, if at all it has to develop. So it is not that big hurdle in women so that they prevent pregnancy. No. These days, because of good glycemic control with modern insulins, it is possible to have absolutely good normal
Near normal
glucose
blood
levels,
sugar,
which can lead to a normal kind of pregnancy and low risk of developing diabetes in future. So if the mother is looking after her pregnancy very well, sugars are nicely controlled, her body weight is okay, blood pressure is nicely controlled, then the chances of acquiring diabetes in these children in future are relatively less. In type 1 diabetes, which is diabetes of children where they acquire diabetes in young age, and when these ladies they become pregnant, actually it is very interesting to know that these children, they acquire diabetes, the chances of acquiring diabetes are 1 in 100 if the lady becomes pregnant after the age of 25, and before the age of 25 it is 1 in 25. If the father is diabetic, actually the chances are little more as compared to the mother.
And this is a social message I think that should go through. It is interesting, as Dr. Sailesh has pointed out, that if the father is a type 1 diabetic, the chances of the child being a type 1 diabetic is 1 in 10. While if the mother is a type 1 diabetic, the chances is only about 1 in 25.
So don't blame the female for.
Don't blame the mother.
Both are
Yes,
equally
absolutely.
responsible. Even
Probably
the males
less
are more.
responsible than the father.
Absolutely.
And that's a very important social message.
Now coming back, Dr. Sridhar, now we will talk a very important issue because once the patient is a diabetic during pregnancy.
Triad of controlling diabetes will be diet, exercise and insulin. As regards diet, which is the mainstay of the treatment, a normal weight lady is roughly given about 30 kilocalories per kilogram body weight. And this is divided into 6 meals, 3 meals and 3 snacks. And there is a feature or a phenomenon called accelerated ketogenesis where ketone bodies are produced in the pregnancy. So it is very important that the lady should not starve. So we should stress on more frequent low calorie meals. And the second thing of course would be exercise. Exercise is definitely beneficial in all forms of gestational diabetes. If just the lifestyle measures are not adequate, then the treatment would be insulin. The best judge to decide whether the patient needs insulin or not is the treating doctor. Please remember so. And also people should remember that insulin does not cross the placenta and hence does not harm the child. On the other hand, not taking insulin would do considerable harm to the child. The type of insulin, whether the short-acting insulin, whether long-acting insulin, whether human insulin analogs, are entirely the decision of the treating
At the
physician.
discretion of the treating physician.
Yes. So, to summarize, diet, exercise, insulin, and sometimes oral hypoglycemic drugs like metformin may be useful in the treatment of diabetes.
Thank you. Dr. Pradeep, does a female who is not a diabetic, when she enters into the menopause, does it pose a greater risk in the menopausal female to develop diabetes?
This is very important questions. Latest study says that menopause itself is a risk factor for development of type 2 diabetes mellitus, and that is independent of aging. Okay. This is because of sudden decrease in a female hormone estrogen and progesterone, which usually have a permissive effect on the insulin action. So sudden decrease in the level of estrogen and progesterone and weight gain will impair the insulin actions and lead to increased risk of diabetes mellitus. On the other side, if I tell you, if the woman is type 2 diabetic or woman is having any kind of diabetes and enter into the menopause, because of the same factor, it lead to a lot of fluctuation in blood sugar level, which imposes a lot of challenge in the management of diabetes mellitus.
We know there are lot many patients, young females, who are type 1 diabetic and they have to take insulin throughout their life. When they get married, they have to plan their family, and if they have to plan their family, are there any challenges, or they have to control the blood sugar very effectively? What are the targets and what she has to do when she becomes pregnant? Because a lot of myths
Yes.
associated with it, particularly in the patients who are on insulin.
You see, gestational diabetes, which a woman will develop say 20-22 weeks after they are pregnant, generally does not affect the child, because the child's main organs are already developed before the mother's sugar has started going up. In type 1 diabetic, a lady who has been a type 1 diabetic since childhood and now has become pregnant, she was already having high sugars before she conceives. And these children are, if they are exposed to high sugars at the very
At the
onset
time of conception.
at the time of conception, at the first few weeks when the major organs
Very
are forming, that can be a bad thing. Now they marry and now they are planning a family or planning to conceive, they need to be more aggressive about their diabetes control than they already were. Now all of these type 1s will already be on insulin, but this is a time when they definitely should be on what is called a basal bolus insulin concept, where they give a bolus insulin at bedtime and 3 shots of short acting insulin before each meal, and titrate the insulin accordingly so that the blood sugar remains absolutely controlled. In fact, we know that the HbA1c should be 7 for normally diabetics, but for such ladies who are planning a pregnancy, the HbA1c should be as close to normal, even non-diabetic levels as possible. In fact, the target now recommended is 6.1.
Sailesh, now it is a very common notion, the patient comes, doctor, I have to go for cesarean section because I am a diabetic and I can't have a normal delivery. What is your opinion in this regard?
Actually, cesarean section in diabetics, they are done more frequently. Of course, that is true. But there are several reasons for that, why it is done or why it should be done. And if you want to prevent cesarean section, the lady has to start preparations even before conception.
Excellent.
So you make your body fit, reduce your weight, do good sugar control during pregnancy, prior to pregnancy, so that your baby is not abnormally large at the time of delivery. If the baby is below 3.5 kgs, there are very few chances of getting into cesarean section. If the baby is large, 4 kgs or beyond that, then of course it's a clear indication for cesarean section.
It may prevent some complications?
Yeah, because large delivery with a large baby through normal passage would be troublesome for the mother and for the baby also. Even fetal death can occur.
So naturally the choice
lies with the treating obstetrician.
Obstetricians.
Yeah.
So, but as endocrinologist, you have to tell the patient they control your diabetes, so the baby doesn't become large. There is no increase in the amniotic fluid, and to prevent the delivery related complication. So your role is very important with the patient to control diabetes.
Yeah, to some extent that is preventable.
Yes. Dr. Sridhar, now it's very pertinent question that a diabetic female, when she gets married, so normally it is a very common notion that she won't be able to conceive because there is increase the infertility rate in the diabetic woman, and even if she conceives, there are chances of recurrent abortions. So, do you think is a fact or is just a myth?
Unfortunately, sir, this happens to be true in the sense the diabetic ladies have great difficulty in conceiving. Now, I would like, why this happens, I'd like to divide it into two types of diabetes. As regards type 2 diabetes, it's as alluded to earlier, polycystic ovaries is very common.
Okay.
And in this condition of polycystic ovaries, one of the main consequences is the inability of the egg formation. So these women do not ovulate very easily. So that is the main reason why they do not conceive. There are certain hormonal disturbances in the hypothalamus which causes the periods to not come for many months. We call this amenorrhea. And again, there can be excess bleeding also. So both these factors can probably cause difficulty in conceiving.
So there are certain factors which really relate to the female for getting conception and is very difficult. What about the recurrent abortions?
Now, as far as the recurrent abortions are concerned, the abortion rate in any diabetic lady will be around between 8 to 10%, which itself is very high when compared to a non-diabetic population. But if there is a long duration of diabetes, more than 10 years of diabetes, and if the HbA1c is pretty high, then it will mean nearly 50% chance of recurrent abortion.
Thank you, Pradeep, the last batsman. Now it is a very common social practice that a female will come to your doc, can I breastfeed my child because I am a diabetic, I may not pass diabetes to the offspring because I am a diabetic, and if she is on treatment, moreover she will be afraid to continue breastfeeding because she might think the medicine will pass through the breast milk and will affect the child.
Absolutely, it is a myth. There is no risk of transferring diabetes from mother to the child if you are lactating. On the contrary, I will say that you must breastfeed your child till the age of 1 year. That is very important, and absolutely there is no risk like that.
Actually, breastfeeding has been shown to protect children from type 1 diabetes. The longer you delay cow milk initiation, the better the children apparently are protected from the type 1 diabetes. And so breastfeeding at least till 1 year is.
Thank you, dear doctors. It was a wonderful discussion. We discussed a lot of good things about diabetes and women, and we really removed all the myths and misconceptions associated with diabetes. With this note, we come to the close of this episode of Beat Diabetes. We'll be meeting you soon with another episode.